that is today is World Lymphoma Awareness Day, and hence it's an apt day for this specific topic. On behalf of Zydus Life Sciences, I would like to thank all the researchers, clinicians, and their support teams who have been working relentlessly in improving outcomes for thousands of lymphoma patients in India and outside India. Before we commence the proceedings for today's webinar, I would like to welcome and introduce the host and the convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit is a very knowledgeable, dynamic, and passionate clinician and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Let me share the screen. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than very well-known personality, Dr. Shankara Panisher from Birmingham, UK, and he's going to lecture us on how do I manage indolent lymphomas in 2024. This webinar is brought to by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Avriti Baveja from Dehradun. Our guest speaker for the day, Dr. Shankara Panisha from Birmingham, UK. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 21st of September 2024, from 7 p.m. Indian Standard Time and 8:30 a.m. US Central Time, we have Professor Dr. Anand Patel from Chicago, USA, speaking to us on non-transplant treatment of MPN in 2024. And the following day, that is Sunday, 22nd of September 2024, from 11:30 a.m. Indian Standard Time and 7 a.m. UK time, we have Professor Dr. Andrew Davis from Southampton, UK, speaking to us on new approaches to relapse and refractory DLBCL. Let me introduce our discussants for the day, and we have galaxy of them here displayed in alphabetical order. To start with, we have Professor Dr. A.K. Tripathi from Sanjay Gandhi PG Institute of Medical Sciences, Lucknow. Dr. Aditya Jandial from Homi Baba Cancer Hospital and Research Center, Mulanpur, Punjab. Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Ami Patel from Blood and Cancer Institute, Surat. Dr. Avrita Baveja from Himalayan Institute of Medical Sciences, HIMS, Dehradun. Dr. Dipjot Pusti from Institute of Medical Sciences and Some Hospital, Cuttack. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Kartik Purohit from Zydus Hospital, Vadodara. Dr. Hasmukh Palar from Blood and Cancer Institute, Surat. Dr. Kunal Goel from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. Colonel Dr. Kundar Mishra from Command Hospital, Lucknow. Dr. Malikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bengaluru. Dr. Mithun Abraham Prakash from Christian Medical College, Vellore. Dr. Mohammad Mir Hussain from SKIMS, Srinagar. Dr. Nadim Shoket from American Oncology Institute, Jammu and Kashmir. Dr. Nakul Tikare from RGCIRC, Rohini, New Delhi. Dr. Narendra Agarwal from Rajiv Gandhi Cancer Institute, New Delhi. Dr. Nilesh Vasekar from Medicover Hospital, Nashik. Dr. Pankaj Tatia from Acharya Tulsi Regional Cancer Center, Bikaner. Dr. Priyanka Samal from IMS and Some Hospital, Bhubaneswar. Dr. Reena Nair from Tata Medical Center, Kolkata. Dr. Rupam Deka from All India Institute of Medical Sciences, Guwahati. Dr. Satyarupa Mohapatra from Pakchi Shri Shankara Cancer Center and Research Institute, Bhubaneswar. Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow. Dr. Saurav Kumar Mishra from AIMS, Bhubaneswar. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Urmimala Bhattacharjee from NHS Foundation Trust. Dr. Vishnu Sharma from SMS Medical College, Jaipur. Now it's the time to introduce our guest speaker for the day. We have with us Dr. Shankara Panisha from Birmingham, UK. He's a very well-known personality, has delivered multiple lectures in MHG before also, and it's always pleasure to hear Dr. Shankara Panisha. Dr. Shankara Panisha requires no introduction, but it's my duty to introduce him. Dr. Shankara Panisha is consultant hematologist, Honorary Associate Clinical Professor at Birmingham Center for Cellular Therapy and Transplant and University of Birmingham, UK. He is a consultant hematologist with over 2 decades of experience in the treatment and management of blood disorders, including leukemia, lymphoma, and myeloma. He sees patients at the Queen Elizabeth Hospital, Birmingham, the Spire Little Aston Hospital, and Spire Parkway. He earned his primary medical qualification at Mysore University, India, and later earned his degree in general medicine at Bombay University. He then undertook his basic training at the Royal Marsden and Royal Free Hospital, after which he completed his specialist hematology training at the prestigious West Midlands Deanery. He then focused his career on myeloma and venous thrombosis research at Warwick University, where he gained knowledge and expertise in the treatment and diagnosis of these disease areas, in addition to the effective treatment of lymphoma, myeloma, inherited thromophilia, and stem cell transplant. Upon completion of his research, Dr. Panisha was appointed consultant in 2017 at the Heart of England NHS Foundation Trust, where he has since been appointed principal investigator as well as sub-investigator for several hemato-oncology clinical trials. He is also actively involved in scientific research and has authored several peer-reviewed articles in renowned journals, medical journals. He has also presented his research at national and international conferences. And today he's going to deliver a lecture on how do I manage indolent lymphomas in 2024. But before he does that, let me introduce our special guest and chief guest for the day. We have with us Dr. Avriti Baveja from Dehradun. Dr. Avriti Baveja is consultant hematologist at Cancer Research Institute, Himalayan Institute of Medical Sciences, HIMSS, Dehradun. It's my privilege to welcome Dr. Avriti Baveja to inaugurate our webinar and give some words of wisdom. Well, thank you so much. Over to you, Dr. Avriti Baveja. You are muted, Dr. Avriti.
Thank you so much for this kind introduction, sir. Good morning, everyone. At the outset, I would like to thank Dr. M.B. Agarwal, sir, and the MHG group for having me here. I'm humbled and honored to be the chief guest for this session, which is the part of sir's passionate teaching endeavors. As we all know that hematology is a dynamic and a very challenging branch where to keep ourselves updated is the need of the hour. These seminars, under the able guidance of M.B. Agarwal, sir, and the MHG group are running seamlessly for years. It is a platform which amalgamates the knowledge of the seasoned hematologists of our nation and our global experts, making an opportunity of great learning for all the budding hematologists. It is just a click on the link that we can keep ourselves updated to learning the innovations in the field of hematology. Even sitting in the remotest areas, we can provide standard of care practices to our patients. In the end, I would urge all the students who have joined the session that one should embrace all the new challenges in their life with grace and compassionately work for the cause of humanity. Thank you very much.
Thank you, Dr. Avriti Baveja, for that kind words of wisdom. Thank you so much for accepting our invitation as our chief guest for the day. Thanks a lot. And now, Dr. Sankara Panisha, sir, screen is yours. Please go ahead.
Thank you, Amit. Looks like I've got a slight hitch. Give me only 1 minute. I will share my screen and then I can start. What a great pleasure to be with all of you. May I start by thanking Professor Agarwal for this kind invitation, and also Amit and Dr. Baveja for what a great introduction for today. It is indeed a privilege to be on the World Lymphoma Day with you all, but most important, yesterday was Hindi Divas. That is when Hindi was chosen as the national language, and you can see all the negotiation people had to do behind the scenes to make it happen. And I note that quite a few people are from Kerala on the call, and happy Onam. With that introduction, let me get on to the current day discussion. Having been here many times, what I have done today is taken a bit of a liberty in terms of the choice, because indeed low-grade lymphoma is vast. As the slide you can see, more than a third of all of our non-Hodgkin lymphoma come under the category of indolent lymphoma. So to make the best use of our time, what I'm doing is concentrating on the two subtypes of the indolent lymphoma for discussion today: follicular lymphoma and marginal zone lymphoma. I'm sure we'll have a lively debate and pick up any other discussion in the Q&A session, because we have a lot of eminent people in the discussion. So what I thought I will do is go through the background of follicular lymphoma a little bit, and again recap the things you already know about the prognostic markers, touch upon, and also we look at how do we manage follicular lymphoma in the frontline setting and also in the relapse, and we look at available clinical trial. With this background, follicular lymphoma is the most common indolent lymphoma and contributes to about a third of all non-Hodgkin lymphoma, both in Europe and UK. I'm sure the numbers will be similar. What we have observed with the introduction of the rituximab is the improved survival, and now the most patient with follicular lymphoma can expect a survival in 1.5 to 2 decades. And follicular lymphoma is characterized by the translocation 1418, which leads to overexpression of BCL2, with so much improvement in the treatment and the prognosis much better. I think where we need to concentrate is identifying people who are poor prognosis, particularly way of identifying people who may be in the POD 24. And even in 2024, unfortunately, follicular lymphoma remains an incurable disease, which is effectively managed, but only treatment which can achieve a cure is allogeneic stem cell transplant, whose indication is decreasing. But we do have a CAR T therapy emerging, and CAR T therapy may be potentially curative in some proportion of follicular lymphoma. And it is great to know in 2024 we have a fully Indian prepared CAR T available in India. With this background, what I thought I do is to look at prognostic indication, the FLIPI-1, using 5 parameters: lymph node site, LDH, age, staging, and the hemoglobin less than 12 or more, was devised in the pre-rituximab era patient, identifying patient into 3 groups: low, intermediate, and high. Is predominantly identified the risk of overall the chances of patient with the follicular the lymphoma surviving 5 years and 10 years, and we can see over 7 out of 10 patients with a low FLIPI-1 score surviving 10 years. Because of the main caveat of the FLIPI-1 being a non-rituximab exposed patient, FLIPI-2, again using similar age, hemoglobin, but some of the simple laboratory markers like the beta-2 microglobulin, marrow involvement, and as a marker of the tumor burden, looking at the more than 6 centimeter greater lymph node size, again categorized into 3. Here we are able to estimate the progression-free survival at both 3 years and 5 years, and people with a low FLIPI-2 score having a remission of more than 80 years. And we also have even more simplified prognostic marker following the PRIMA study, only using the beta 2 microglobulin and marrow involvement, with the high risk group being the beta 2 microglobulin more than 3. This has enabled us not only to provide prognostication, but also may be able to look at different treatment options. But in 2024, I think we predominantly use Flippy in our decision making because of quite a how do we even substratify very high risk patients with the exponential growth of molecular markers. We do have this M7 Flippy, where we can identify very high risk patient with follicular lymphoma who probably will be in the POD 24, POD 24 group by using 7 genes in addition to Flippy and a performance status. So even in 2024, the standard treatment for follicular lymphoma only applies when there is clinical criteria are met. Previously, we used to use the BNLI criteria, but now our treatment decisions are mainly dependent on people meeting the GELF criteria as highlighted above. So mainly it's tumor size of more than 7 centimeters, or we do have 3 nodes in 3 distinct areas, which is more than 3 centimeter. Patients having symptomatic splenomegaly or lymphadenopathy, which is causing organ compression, and then some involvement of the ascites or pleural effusion causing symptoms, and presence of B symptoms. Generally, the systemic symptoms and B symptoms are less common in follicular lymphoma. And if you do have a cytopenia, which is because of the marrow infiltration, which is an indication for treatment. So, first of all, I wanted to have a discussion for how do we treat localized or limited stage follicular lymphoma, which is mainly stage 1A and 2A. Here, involved field radiotherapy, the ISRT, or involved site radiotherapy, and generally the recommendation is 24 gray over 12 fractions. And in the era where PET is widely used in the staging, this can be potentially curative in about 40% of patients. And what I've highlighted here from the Peter Seton paper, that chances of somebody relapsing is less than 2, that is percent 1 in 50, if somebody is in remission beyond 5 years after the radiation treatment. From UK, we did had a fourth study which looked at 24 gray versus 4 gray. What the study showed is, even though there is no difference in the overall survival, local control was much better in with the 24 gray. So that is why current standard of care remains 24 gray in 12 fractions. I'm just highlighting how staging is important. If you can see again from this collaborative study, if you are stage 1, you are more likely to have a significant better outcome following the radiotherapy as compared to stage 2. Now, the question arises is, how do we manage a follicular lymphoma patient who are asymptomatic, but there is no indication for treatment? The standard for majority of these patients till now, based on the previous BNI study of chlorambucil versus watch and wait, has been the watch and wait. But has this watch and wait changed in 2024 with the advancement of all the novel treatment? Again, I have the option of presenting you here the study from a multinational study run by my colleague Kirit Adarshna, which started with a 3-arm study of standard of care being the watch and wait, whereas 2 arms of the rituximab, one where patient only had 4 doses of weekly rituximab compared to the 4 doses of rituximab followed by rituximab maintenance for 2 years. Now, this study has got a long-term follow-up, and I present here a key headline message being watch and wait versus observation did not make any difference in terms of the overall survival, or it also did not make any difference in terms of the high-grade transformation. What it really made a difference is time for the next treatment was significantly better by having the rituximab, and also the progression-free survival is significantly better. But we are comparing patients who did not have treatment to patients who did had a rituximab maintenance. Based on this study, we can say for asymptomatic stage 3 or 4, rituximab is an option, and it also takes away the watch and worry component for some of our patients who are being managed, particularly both in CLL and low-grade lymphoma. We had to recoin watch and wait into active monitoring to take away the patients interpreting as watch and worry. Now, when we come to the frontline management of follicular lymphoma, in the last 15 years, starting from the Robert Marcus pivotal study of CVP versus RCVP, we have a flurry of clinical studies, which I will identify in a minute, have identified chemoimmunotherapy is the current standard of care. And based on the PRIMA study, again, rituximab maintenance following the first line chemoimmunotherapy has become the standard of care. Here, for the benefit of the trainees, I've identified the different option, which is following BR or CHOP to our CVP. We will also have an option of discussing about the gallium study and the role of alternative CD20. I will focus the second line treatment subsequently. For the benefit of the trainees, what I've done here is only chosen 4 trials to summarize, comparing the different chemotherapy option based on the Matthias Rommel data, where bendamustine is resurrected from the East Germany, making a significant difference in the management of follicular low-grade lymphoma. This study did show BR was better to R-CHOP in terms of the progression-free survival. We have the BRIGHT study, which showed bendamustine rituximab is non-inferior to R-CHOP, but the BR was much better tolerated. The only one side effect, which was slightly higher in the bendamustine, is the vomiting and sickness. Then we have the recent trial gallium looking at the second generation anti-CD20 versus rituximab, which showed there is a progression-free survival advantage of obinutuzumab over rituximab in whatever the chemotherapy combination, varying from bendamustine, CHOP, or CVP. And there is also time for the next treatment is better with obinutuzumab. In spite of this advantage in terms of the progression-free survival, the general uptake of obinutuzumab is not that much. And then it is always very uh, interesting and also emotional from the patient perspective is the chemo free, and R square being a chemo free, it did show that it is again non-inferior to the chemo immunotherapy, making an R square lenalidomide and rituximab is an alternative, particularly in the Indian context. The lenalidomide may be financially, the financial toxicity may be far better as compared to the chemoimmunotherapy. So what I thought here, with the interest of the time, I summarize my own approach to the management of advanced stage follicular lymphoma. So R-CHOP and bendamustine rituximab remains the more well-used options in my practice, and I do use CVR, CVP in people who may not be fit to have the bendamustine rituximab. The bendamustine usage has been associated with the less toxicity, and if there is an occult transformation, then R-CHOP is better, particularly following the gallium study with some of the concerns raised regarding the longer term infection risk. And we are all still scarred or recovering from the impact of the pandemic, which has changed our approach post-pandemic, that bendamustine use in the frontline follicular lymphoma may be slightly decreasing as compared to the resurgence of the R-CHOP. Based on all the current available treatment, rituximab maintenance is the standard of care, as it decreases the chances of the progression by 50%. But important to note that so far, rituximab maintenance has only shown progression-free survival benefit, but not overall survival benefit. We are waiting the outcome of a again multinational study called the Petria, which is again looking at the role of rituximab maintenance, and potentially either any patient with follicular lymphoma who can be spared of rituximab maintenance without compromising the care. This is a very relevant question when some of our practices got altered during the COVID pandemic, in the post-COVID pandemic. In my practice, the lenalidomide and rituximab R square is mainly as a second line or subsequent line treatment. There is a role for obinutuzumab, and predominantly my use of obinutuzumab is if I'm opting for CVP. So I do use OCVP because of a longer PFS and the longer time for net treatment. But I tend to use significantly less obinutuzumab in combination with either CHOP or bendamustine in the first line setting. Coming to the second line treatment, again, we have plenty of options going from bendamustine, rituximab, and bendamustine, obinutuzumab, or R square. So it's mainly if I have used bendamustine rituximab in the first line setting, it will be the R-CHOP. If I used R-CHOP, it will be in bendamustine rituximab. But if there is a definite rituximab refractory, that is patient progressing within 6 months of the last of the rituximab, or while on rituximab maintenance, there is good evidence from the Gadolin study to consider bendamustine obinutuzumab. And in UK, we do have, based on both Magnify and Augment study trial, opportunity to use lenalidomide and rituximab. There is wide range of treatment options when patients have already had 2 lines of treatment, change from significant number of PI3 kinase inhibitor. They were in the clinical trial. Unfortunately, because of the toxicity, FDA has suspended many of the PI3 kinase trial. So I'm not aware of any PI3 kinase now being explored, and we do have EZH2 inhibitor tazemetostat. And I think what's going to be in the next few years is the CAR T therapy and also the bispecific or BITE. Here, I just wanted to update a bit more in detail about the augment, and also we can magnify, and hopefully in this ASH we may hear something called study called the InMind, where patients had either tocilizumab or placebo in addition to the R square. So the augment nearly 200, just less than 200 patients in each arm were randomized to either rituximab or in addition to lenalidomide or placebo. 12 cycles of the treatment, and the rituximab is in the first 5 cycles, which clearly showed there is a progression-free survival advantage for R square as compared to rituximab alone. You can see there is slightly differential progression-free survival when we look at the investigator assessment, which is 14 months versus 25 months, as compared to almost tripling of the progression-free survival advantage with the independent assessment. We do have a role of both autologous stem cell transplant and allogeneic stem cell transplant, particularly the autologous stem cell transplant in majority of the parts of the world remains a good option for POD24 patients with follicular lymphoma. But in 2024, I can say that there is very little role outside of a clinical trial for autologous stem cell transplant in CR1 or at first response. I've summarized here data between the autologous and allogeneic stem cell transplant from the NCCN follicular lymphoma database, which clearly shows the overall survival is better with autologous stem cell transplant as compared to allogeneic stem cell transplant. But we are comparing an apple to an orange, as patients who did undergo allogeneic stem cell transplant may have had a prior autologous stem cell transplant or much more higher risk. So allogeneic stem cell transplant remains a possible option for minority of patients with follicular lymphoma, but the indication for the follicular lymphoma in 2024 has been squeezed by the introduction of CAR T therapy and also the bispecific. Just for the benefit of the the trainees, I just wanted to go through Zuma 5 study, which is from Gilead Kite, looking at the axis cell in low-grade lymphoma and two predominant category of patients being fludarabine, follicular lymphoma and marginal zone. Here, patients with either follicular lymphoma, marginal zone lymphoma, who had at least two or more than two lines of treatment, who were had a lymphodepleting chemo with fludarabine cyclophosphamide. The dose of the lymphodepleting is similar to what it was in Zuma 1. Fludarabine is 30 milligram per meter square for 3 days on day -5, day -4, and 3. And the cyclophosphamide is also similarly 500 milligram per meter square with 2 clear rest days followed by the CAR T cell infusion. So there are over 80 patients with follicular lymphoma in the Zuma 5, with about 20 patients of the margin zone type. And when the pivotal result was presented with a nearly 18 months of follow-up, it clearly showed there is some amount of the flattening of the survival curve, suggesting a potential, whether it may be curative option. What it clearly showed is there is a progression-free survival and overall survival benefit as compared to the conventional alternative treatment option. The landscape of our lymphoma treatment on this World Lymphoma Day has changed with again the introduction of the bispecifics, and we do have good data of mosunetuzumab in follicular lymphoma, and there is multiple other bispecific, including Odro, Epcor, and glofitamab. In terms of the being fair, we also have data of T-cell in the follicular lymphoma, but T-cell is not available in UK, but it has got an FDA approval. So with this, what I wanted to summarize the follicular lymphoma is the introduction of the rituximab and the chemoimmunotherapy, and the rituximab maintenance has changed the landscape, and now majority of patients with follicular lymphoma can expect a survival of 1.5 to 2 decades. Even in 2024, in the absence of patients meeting the criteria, GELF criteria, watch and wait is an option. In my practice, I don't do watch and wait for stage 1A, as a proportion of these patients with the involved site radiotherapy in the PET staging era can be potentially cured. Plenty of small molecules, bispecifics, and the T-cell engagers, and also the CAR T have exploded the second, third line option in patients with follicular lymphoma. But I think the key for all of us with such a prolonged duration of survival is to look at any ongoing clinical trials and exploring the trial options for our patient with follicular lymphoma. Now, in the remaining minute, I just wanted to run through marginal zone lymphoma and recap our treatment options. Then we can have a question and answer session looking at other lymphoma. When we use the term marginal zone lymphoma, it will be predominantly three categories: extranodal or mucosa associated, which the predominant category, more than 2/3 of all marginal zone lymphoma will be of this type, whereas splenic margin zone lymphoma is about only 20%, and nodal margin zone lymphoma is less than 1 in 10 patients with margin zone lymphoma will be of this category. So what is beautiful about the margin zone lymphoma is a clear link between the infective pathology and the type of the mucosa associated with the gastric is all about H. pylori. And even in the absence of the H. pylori, the first line treatment has always been the H. pylori eradication. None of us have been able to repeat some of the success our Italian colleagues had in the orbital malt, particularly the conjunctival, with the doxycycline treatment for 21 days. I think it's very important for us to make sure we have excluded hepatitis C in splenic lymphoma, as the treatment of the hepatitis C can give to the resolution of the splenic lymphoma. With this, I just wanted to go through the treatment algorithm for the localized malt lymphoma. It's predominantly remains the antibiotic treatment as the first line treatment. I will go in a little bit detail regarding the gastric malt. As far as the ocular malt, it is important to give a trial of doxycycline, predominantly based on the Italian study, as a proportion of patients may achieve clinical remission, including complete remission. But unfortunately, in my practice, I've not been able to get a similar outcome as the Italian study. So a good proportion end up having a radiotherapy, which provides a significant option. Whereas for the advanced malt lymphoma, it's no standard of care. So we do use similar GELF criteria to make a decision. And here we have the option from R chlorambucil to R CBP or bendamustine, and a minority of patients having R-CHOP. So just to run through gastric malt lymphoma, so it's mainly is testing for the H. pylori. We do know the presence of the malt gene rearrangement with translocation 1118 is associated with the failure of the H. pylori eradication. The key is to give a sufficient time after the H. pylori eradication to do the restaging investigation. In my practice, I retest at least 2 months after the H. pylori is eradicated, and then nearly about 3 to 6 months, following which will be a repeat endoscopy to confirm the resolution of gastric malt. But after 6 months, if there is a failure of the H. pylori eradication, even on 2 occasions, then I will proceed with the either local radiotherapy, or if some reason local radiotherapy is not option, then you have the opportunity to use some chlorambucil, bendamustine, rituximab, single agent rituximab. And if patients do achieve a good response to 4 cycles of bendamustine rituximab, I generally stop at 4 cycles rather than going for the 6 cycles. As far as the nodal margin zone lymphoma, which is less than 10% of the margin zone patients, its treatment is similar to the follicular lymphoma, localized versus advanced. If localized, similar 24 gray radiotherapy in 12 fraction. And for advanced, again, similar to follicular lymphoma, if they don't meet the GELF criteria, watch and wait. But if there is a presence of the GELF criteria, a option to use between single agent rituximab to chemoimmunotherapy. In my practice, I tend to avoid rituximab maintenance following the first line treatment in margin zone lymphoma because of the very good outcome, and also the use of the rituximab maintenance has slightly changed following the post COVID pandemic. As per the splenic margin zone lymphoma, it mainly is to identify there is no hepatitis C and the management of the hepatitis C. Next is to look for the presence of any cytopenia or pain. If those are not there, observation. But if they do have cytopenia or discomfort from the splenomegaly, then it is the option is between splenomegaly and rituximab. In my practice, single agent rituximab turned out to be excellent treatment. I do use 4 doses weekly, and if they achieve good response, 4 more, 3 weekly, and we do have the data from the LymphoCare showing that single agent rituximab, the outcome is similar to the chemoimmunotherapy. But if you don't have a response to the single agent rituximab, it will be chemoimmunotherapy, similar to what we discussed in the follicular lymphoma. So just to summarize, what is the BCSH recommendation for marginal zone lymphoma is for the MALT is appropriate antibiotic for eradication of the H. pylori or other suspected antimicrobial the microbe. Involved field or involved site radiotherapy for the localized, and for the advanced is between single agent rituximab to chemoimmunotherapy. And I use R-CHOP if there is a confirmation, whereas for the nodal margin zone lymphoma is similar to the follicular lymphoma, and for splenic margin zone lymphoma is observation, no symptoms, or there is symptoms, rituximab monotherapy, and splenectomy is an option in selected cases, whereas for the second line is similar to the follicular lymphoma we discussed, is the sequencing based on what we choose as a first option. Because there is no standard of care in margin zone lymphoma, it is good to enroll patients in clinical trial if we do have a clinical trial. With this, I just wanted to update some of the new developments in the field of margin zone lymphoma, because marginal zone lymphoma, like follicular, is incurable, and patients do relapse after the first line treatment. For the benefit of the trainees, I've put in this slide, which shows various treatment options with the overall response rate to different agents. And you can see The best response is to the CAR-T and zanubrutinib, again similarly has a overall response rate of nearly 70%. And I just wanted to highlight some of the BTK inhibitors which is used in the margin zone lymphoma. And currently, we do have zanubrutinib approved in UK based on the Magnolia. This is patients who are relapsed, having zanubrutinib either 150 milligram BD or 320 milligram BD is nearly 70 patients in this Magnolia study, and which is slightly different. Some of the eagle-eyed among the trainees may have noticed that the different sub-cohort of margin zone patient in Magnolia is all one-third, 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 which is very different to the patient cohort you may have picked up from the augment study, where there were a lot more of one particular type, whereas Magnolia showed a very good progression-free survival in this cohort of people who are relapsed. We did touch upon the Zuma 5 trial with follicular lymphoma. About 20 patients in the Zuma 5 were also with the margin zone lymphoma. Clearly shows the overall response rate is about 9 out of 10, with nearly 6 out of 10 achieving complete remission, and the progression-free survival is 12 months as compared to 83% progression-free survival with zanubrutinib at 1 year. And we do have the subcohort of either the Magnify trial where about 76 patients were of the margin zone lymphoma type. The overall response rate of 64 and 39% CR rate. We do have a 41-month progression-free survival. So with this, I wanted to summarize the progress we have made in the margin zone lymphoma. Unfortunately, margin zone lymphoma, like diffuse large B-cell lymphoma, remains a heterogeneous, and there is no one standard of care even in 2024, which makes us all to explore clinical trial and frontline management for margin zone. There is a proportion of people who will need watch and wait, whereas the antibiotic treatment remains the cornerstone for the majority of the mild lymphomas. And if they do fail antibiotic treatment, then it's a radiotherapy versus single agent rituximab. Whereas splenic margin zone lymphoma, there is a significant benefit of single agent rituximab, only minority needing chemoimmunotherapy, whereas the nodal we manage like follicular lymphoma. In the relapse setting, I think now highly likely the BTK inhibitors remain the cornerstone, and the FDA has suspended the development of the PI3 kinase inhibitor, with the cellular therapy coming into option. CAR-T remains both for follicular and margin zone lymphoma. With this, I will stop here and stop sharing my slide. With the interest of the time, I haven't discussed the Richter's, the high-grade transformation. Sorry, we can pick it up in the question and answer session.
Thank you, sir, for that wonderful talk. As always, always good to listen to you, learn from you. Thanks a lot. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Sankara Panisha. Yes, Dr. Upendra Sharma sir, please.
Thank you, doctor, for that wonderful presentation. So, my question, just to elaborate in your presentation for those patients with low-grade follicular lymphoma, you said that your rituximab maintenance, you don't prefer usually rituximab maintenance. So, in what certain subset of patients do you prefer rituximab maintenance in follicular lymphoma? And
It's a
whether do you
great-
prefer rituximab maintenance after BR therapy?
It's a great question. If we go with the evidence, the current standard of care should be based on the follow 5 prima. The rituximab maintenance should be the standard of care, but all of our practice have sudden changed to some extent following the COVID pandemic, where we suspended rituximab maintenance because of the poor response to COVID vaccination, because the COVID antibody level within the 12 months of the rituximab exposure or any anti-CD20 is minimal. Having said this, we are waiting eagerly the outcome of the Petria study, which is clearly going to answer. In my practice, if there is any concern for infection and if patients are in complete metabolic remission, it is reasonable to not offer rituximab maintenance, but this is only personal choice. But based on the current available evidence, because of the more than 50% reduction in the progression-free progression, we do need to offer. But you clearly highlighted a point about the bendamustine and the use of the bendamustine and the maintenance, whether rituximab or obinutuzumab maintenance have associated with the increased risk of infective complication. Now, much more of an interesting debate is about the role of rituximab maintenance following the mantle cell lymphoma. Their evidence is for much better for the CHOP-based treatment, whereas following the bendamustine rituximab, the advantage of rituximab maintenance in mantle cell lymphoma is less clear. I hope I have given a nuanced answer, and until we get the outcome from Petria, we don't have a definite evidence not to offer rituximab maintenance.
Thank you.
Thank you, Dr. Upendra Sharma. Dr. Aditya Jandia, the question, please.
Good afternoon, sir. Thank you, Dr. Panisha, for the fantastic presentation. So, I have two questions for you, just practical questions. So, in a patient with follicular lymphoma, if we have used bendamustine rituximab as first-line therapy, how often you reuse bendamustine in later lines? That's number one. Number two, in some patients, we have seen sometimes infections happening once the patient is recovering after receiving 6 cycles. So, is there any role of looking at the CD4, the lymphocyte subsets in patients who are who already subjected to bendamustine?
It's a great question. Thank you, Aditya. So I will pick the second question first, because that makes it, because of my transplant role and also because of the role with the CAR T, we regularly monitor CD4 count, and my own practice has always been, if the CD4 count is less than 300, to continue with the both PCP prophylaxis and also the acyclovir prophylaxis to reduce not only the shingles but also any other herpes. So that has been mine. And also worth is looking at the immunoglobulins. The immunoglobulin replacement has been very difficult because of the access and the shortage. So whereas antibiotic prophylaxis makes a difference, in my own practice, if the immunoglobulin levels are lower than 5, I do suspend rituximab maintenance. So as per the Vanover initial second line there, because the clear, if the immunoglobulins are low, to suspend the rituximab maintenance. Particularly, we are all being scarred with the our practice to some extent has changed during the COVID. And your question directly relates to the extended analysis of the gallium data, looking at why there was slightly more infection and morbidity and mortality that clearly identify the post-bendamustine use, whether it is a rituximab or obinutuzumab, there is the cytopenia. So answering to your first question is, I think this is where it might answer Dr. Upendra Sharma's first question is, if you did had a bendamustine rituximab and patients are in complete metabolic remission, there it is reasonable not to give rituximab maintenance. If you do remember Matthias Ramel data, there's a cohort of the still patient, one cohort did not get rituximab maintenance, and the outcome was significantly better in terms of the progression-free survival. So that may be the one way of how do we stratify our treatment option. Whereas if people are getting CVP, then it is much probably to get the best out of the CVP to use either rituximab or obinutuzumab maintenance.
So just wanted to reiterate, do you ever use bendamustine later in follicular lymphoma?
Thank you. Again, very interesting question, because if there is a rituximab refractory, because then if you have used BR, it is potentially possible still to use BO. So, but if somebody has already progressed on bendamustine, rituximab, re-challenge, but the issue with the bendamustine remains because it is a component of the purine analog. So the risk of myelodysplasia and therapy related. So that is why re-challenging with the bendamustine in 2024, when we do have other option, is less, because I think we are all scarred by the therapy related myelodysplasia. So that is why, unless you are using BO for a rituximab refractory, then my own practice is not to use. And other thing we do need to consider in 2024 is the expanding role of CAR T therapy. And with the significant use of the bendamustine, we know the leukapheresis may be impacted. And the other, we already have a clear data both in the mantle cell lymphoma and also in the diffuse large B-cell lymphoma, that any exposure to bendamustine within the last 12 months of leukapheresis, the outcome is inferior. So that is why, even though it is not completely against, but we need to consider all these caveats if we are re-challenging the patient with the bendamustine, because of so many other options. My own practice is, unless I'm using BO, unlikely I will be using more than 6 cycles of bendamustine.
Thank you, Dr. Panisha.
Thank you, Dr. Aditya. Dr. Hasmukh Balan, your question.
Yeah, first of all, thank you, Dr. Panisha, for a crispy and to the point discussion. I have got a 23-year lady, splenic margin and lymphoma, 20 to 20 centimeters splenic size, no B symptoms, and PET CT, there are 2 3 lymph nodes and mediastin and 2 3 periodic, only 2 to 3 centimeter in size. So my question is, first question, would you like to treat her? If yes, then rituximab monotherapy or rituximab plus bandana?
Great question. So my own practice is, because the audio was slightly less clear, but I can reiterate. I will tell the spleen size is 23 centimeters, and patient do have a symptom. So because of that, there is an indication for treatment. And in 2024, and particularly now, we have the data from the LymphoCare single agent rituximab is so much successful. So my first option is to use 4 doses of rituximab weekly and assess. If patient has responded very well, either a PR or a CR, a PR, to give 4 more doses of rituximab, so the 8 in total, like how we do with the cohort of the PTLD, that will give a significant PFS advantage. And splenectomy role is now decreasing because it's a 10% morbidity mortality, and particularly with the increasing spleen size, even with all the laparoscopic. And if patient has got less than PR to the 4 doses of rituximab, then worth combining with the chemoimmunotherapy, whereas to use or decrease the side effects, I prefer single agent rituximab rather than the chemoimmunotherapy for splenic margin zone lymphoma. Hope. Again, it is always very difficult for an individual patient, but without knowing the minute details of the individual patient, so the generic answer should be the single agent rituximab is preferable, and we do have the data to suggest the outcome is much better.
Okay, thank you.
Thank you, Dr. Hashmukh. So from the same note, if the patient is the same patient who has got a moderate splenomegaly, splenic margin zone lymphoma, symptomatic, non-symptomatic to start with, would you wait and watch in such cases?
I think there is a very, because if the blood counts are good, there is no cytopenia, and patient have got no symptoms, it is reasonable to watch and wait, or it is actually the best option, and this patient can have single agent rituximab when the patient gets the symptom. And one of the other option, previously we used to have this patient would have had a bone marrow, and when they developed, they could have had a splenectomy. The marrow infiltration was minimal, whereas with the data we have, the single agent rituximab has changed how we manage these patients.
Thank you. Another question is, if the patient of splenic margin zone lymphoma, which patients do you go for upfront BR therapy, and which patient will you go for upfront R monotherapy? How do you decide that?
Another very interesting question. My own practice has been that as long as I'm very comfortable, there is no occult high-grade transformation, because then I always think in 2024, best to start with single agent rituximab, assess the response after, because you're only within month they would have completed the 4 doses and make a decision rather than jumping suddenly to chemoimmunotherapy. Because have been, even when patients are extremely symptomatic, they give 1 or 2 doses of rituximab, they have completely changed. So that is why, until unless they fail single agent rituximab, Nowadays, my practice is not to use chemoimmunotherapy as a first line in splenic margin zone lymphoma.
Thank you. Another question is a patient of follicular lymphoma, grade 3B, treated on R-CHOP, relapses within 1 year of R-CHOP, not eligible for stem cell transplant. What would you do next?
This is a tricky question. I'm hoping that the current WHO 5, now there is no 3B, so it will be diffuse follicular lymphoma, and the question will be, is it relapsed as a not low grade but the high grade? If it is still in the category of the 3B, even though we are not using it the WHO 5, we do need to make a distinction, and you've already given me the parameter that the patient is not fit for autologous stem cell transplant. So the option here, or whether you are able to use some form of the salvage chemotherapy. I understood that unlikely this patient is for RGDP. So whether you may get away with R-GEMOX is maybe an option, and the other is particularly in the Indian context, you may still be able to use R square, because the lenalidomide has been even with the diffuse large the transformed follicular has been, so R square is another option. But I slightly want to challenge you in a different way, because the autologous fitness is different to the CAR T fitness in 2024. If you do have an option, that is a possibility. When UK, if you have a transformed follicular, it depends upon how we defined the first one. And if people relapse within 12 months from an R-CHOP containing, they may be eligible for the second line CAR T. But to use the second line CAR T, they have to be technically autologous transplant fitness are eligible to the autologous. So probably for your patient, if you do have a much more cheaper access of because this patient meets the POD 24 criteria, but with the 3B, so our GEMOX would be what I was hoping for. Now, even 3B, I don't know precise date of polar BR, because the polar BR has been mainly in the diffuse large vessel category. Can't remember out of my straight away how many patients were of 3B category, but if it is, polar BR is an other option. But in terms of cost-wise, I may have opted for R-GEMOX, because you can go up to 8 cycles of R-GEMOX.
And if the patient enters complete remission after R-GEMOX 8 cycles, then would you offer any maintenance?
Because so all the maintenance has been in the 3A or below, grade 1, 2. So role of maintenance in 3B, either in the first line or the second line, is slightly outside of the evidence poor area. But because of the options are limited, you could use, because there is evidence and very being mindful, because this is a teaching webinar for transform follicular. There is a small proportion may be benefited, but it is not licensed or funded in UK. So you could use that evidence to justify but I'm not aware how many proportion of patients with 3B were included in any of the maintenance study.
Thank you, sir. Dr. Upendra Sharma, your question, please.
Dr. Panisha, so sometimes we have patients of follicular lymphoma where we have indication of treatment. And in those subset of patients, where do you place role of adult vaccination? Now we have robust data for vaccination in our lymphoma or blood disorder patients. So in those follicular lymphoma patients, where do you have indication for treatment? So when you will have the what is the optimal time for adult vaccination in those subjects?
Very interesting question. So, my general practice has always been based on the, we call it as a dead zone. 12 months from after rituximab exposure is when there is a response to vaccination is minimal. So, it is potentially useful to think ahead, like we do exactly like what we do in CLL. When you have identified, you do their vaccination, so they're fully vaccinated when they're having the treatment, including because the hepatitis B vaccination was not a routine for 15, 20 years ago, whereas now hepatitis B vaccination is within the standard regime. But now you may take an option that to minimize the risk of infection, you might want to do the vaccination while they're having, but I feel the response is so poor, best to wait 12 months after you completed a rituximab containing regimen, apart from the COVID. For COVID, and I think irrespective whether they respond or not, you still want to go ahead and do the vaccination, knowing clearly there is 1 in 5, 20% of our patients do not get a humoral, the COVID antibody response. Even after having more than 4 doses of COVID vaccination, they may have a T cell response, but 20% of patients exposed to anti-CD20 don't get a humoral response to the COVID vaccination.
Thank you, Dr. Panisha.
Thank you, sir. Another similar question from Dr. S.K. Sharma. Hepatitis C therapy is finite these days. You have to give for just about 3 to 6 months. But for hepatitis B, it is indefinite. How long do you wait for lymphoma treatment after starting hepatitis B drug, that is tenofovir?
Hepatitis B or hepatitis C?
Hepatitis C is finite therapy, that is 3 to 6 months, but hepatitis B has to be given indefinitely. So once the patient is hepatitis B positive and the patient has been started on tenofovir, how long do you wait for the lymphoma treatment to start with?
So, if there is an indication for treatment, once they're on appropriate hepatitis B treatment, I've been, because we can monitor the liver function test, we can monitor the hepatitis HBV DNA. So that is why, with the prophylaxis, if there is no liver function test, it allows you to start the treatment, and if there is a threatened end organ, I'm happy just after 4 weeks of the appropriate treatment to start the chemotherapy, because we do have ways of monitoring the response to the treatment.
Thank you, sir. Any discussion want to ask any other question? Because there are no more questions in the chat box. Fine, so. Well, Dr. Shankar Panisha sir, for the fantastic and lovely talk. That was awesome. As always, a very, very good learning from you. Whenever you come, I learn something new from you, always. Thank you, sir, for accepting our invitation once again as our guest speaker for the day. and definitely will bother you in the near future also. Thanks a lot.
Amit, always thank you for the nice things you say about people. Indeed a pleasure, and always great to be in the company of Professor Agarwal, sir, because he in 1995 taught us how the 1517 translocation and the ATRA, that all motivated us to turn out to be hematologists. I think Dr. Baveja clearly identified the guidance we all have from Prof. Agarwal. So it is for his credit, everybody who comes in contact with him turns out to be hematologist.
Absolutely, sir.
Thank you.
Thank you so much. And I thank all our discussants and the audience to participate in this webinar. Meet you next week with another beautiful webinars. Goodbye for now.